I'm Dr. Jerry Hesch, a physical therapist from the Hesch Institute in Aurora, Colorado. And as a sacroiliac expert, I'm responding to a conversation on Facebook. And this is the second question that was posed, and it relates to aligning the pelvis in a physical therapy clinic as opposed to aligning the pelvis on the surgical table prior to a sacroiliac fusion, which is actually performed by a physical therapist in at least one part of the country, and it certainly is very, very controversial, as we will come to see. So here's the question. If being fused in malalignment does not cause problems, why would you need to align pelvis at all? And as I stated in the first video question, is that I address alignment as part of a thorough biomechanical evaluation and treatment of the body, but I couple it with passive motion tests through different parts of the pelvis, which is called passive spring recoil testing. So those are always coupled together, whereas this alignment on the surgical table does not include the passive joint motion testing. It only looks at how the pelvis lays on the surgical table. And I'll reiterate, how a pelvis lays on a surgical table has nothing to do with the relationship inside the sacroiliac joint where the sacrum and the ilium articulate. And that's a very important point. I know a physical therapy assistant in Illinois who had sacroiliac fixation, and years after that has seen several people and had them evaluate her pelvis, evaluate positioning of the pelvis, and they tell her that her ilium is rotated on the sacrum and got stuck, etc., which is just absurd. What they're looking at is alignment of the pelvis in space and suggesting that simply because one side is asymmetrical, that implies the movement happened inside the sacroiliac. And I'll comment a little bit more on that. So being that she had surgery, obviously the sacroiliac surgeries do not correct asymmetry of the pelvis. Research shows that movement in the sacroiliac joint in the patient population moves less than 3 millimeters. That's a remarkably small amount of movement from side to side. When you're looking with your eyes side to side of someone's pelvis, do you really think that a physical therapist or any clinician can really see the difference from side to side? Much of the movement that happens when a pelvis presents as asymmetrical does not have to do with movement inside the sacroiliac. And we've been, it's a mythology that's deeply ingrained in our culture, the belief that anytime there's asymmetry, it's because ilium is moved on the sacrum in relationship to the sacrum, or the sacrum has moved in relationship to the ilium, or both of those things. And physical therapists and other clinicians cannot perceive that subtle amount of difference. So what's causing a large observable asymmetry of the pelvis? Movement of the entire pelvis in relationship to the hip joints, in relationship to the trunk, to the spine. That's the answer. Furthermore, research shows very poor agreement between two different clinicians as to the symmetry of the pelvis. So it's, you can have two different clinicians come in, even experts if you will, and look at alignment of the person, and they wouldn't agree between each other. So who's to say that what one of them sees is accurate, even if they've been doing it a long time? I do not believe that a therapist can discern 3 millimeters of side-to-side difference in the alignment of a pelvis. Aligning the pelvis as I do in the clinic as part of conservative care to people who have a diagnosis of sacroiliac joint dysfunction has nothing to do with the relationship between the sacrum and the ilium, except in very rare cases. Again, aligning the pelvis does not change the relationship between the ilium and the sacrum. It is therefore unnecessary for surgical fixation or fusion. Furthermore, as I've stated before, aligning the pelvis in my clinic is based on passive movement tests, which are called passive spring recoil tests, and the goal is to restore normal movement and secondarily to improve posture and improve stability through the structure, through the lumbopelvic hip complex. Alignment theory cannot predict normal asymmetry. When I treat clients, I use extensive testing to determine if there is a fixed asymmetry of the pelvis, a developmental asymmetry in the leg bones, the hip joint, the pelvis. If there is a fixed asymmetry, I educate the patient. And we might use some modification in terms of how they sit to improve sitting comfort. And I have some YouTube videos that describe that as well. I do not tell them this asymmetry continues every time we treat you, and in spite of you doing exercises for weeks, this asymmetry continues, therefore you need a sacroiliac fusion because it's unstable. That is preposterous. And again, some people develop fixed asymmetries over their life, and our job over their early adult life, and our job is to discern that as thorough clinicians to find out when the pelvis can be treated with alignment, with improved mobility and stability, and we need to discern when that cannot be changed. And I feel like that's absent in this approach of aligning pelvises on the surgical table. Last year I saw a woman who was told that she needed fusion with alignment on the surgical table. She had diffuse pain in the thoracic spine, the lumbar spine, and the posterior pelvis. This was an absurd recommendation because she had no passive spring recoil movement in the pelvis throughout with multiple tests, and she had no movement in the thoracic and lumbar spine. What she needed, and again it had been recommended that she get her SI fused with alignment on the table, an expensive procedure. What she needed was referral to a rheumatologist for a medical workup for probable ankylosing spondylitis. Alignment theory could not predict that diffuse stiffness throughout her pelvis, throughout her lumbar spine, and throughout her thoracic spine. Only the passive spring recoil testing informed me and the client that there was no mobility there. There was no hypermobility simply because her pelvis moved asymmetrically with testing did not mean that there was instability. So that's a false positive diagnosis based on alignment alone. It's necessary to test the function of the joint. I conclude that passive spring recoil testing is much more important than alignment testing of the pelvis. In the book, Surgery for the Painful Dysfunctional Sacroiliac Joint, there are multiple contributors to this book, and they came to consensus that alignment on the surgical table performed by physical therapists is an unnecessary procedure and has nothing to do with the surgical outcome. And there are thousands of persons getting this surgery across the world without having alignment. And so the statement, the marketing statement that alignment on the surgical table is necessary to assure a good outcome is marketing hype, and it is untrue. And again, aligning how the pelvis lays on the table and how it looks side to side has nothing to do with the relationship inside the sacroiliac joint in relationship to the sacrum and the ilium. However, those who profit from alignment theory are heavily invested in having you believe otherwise. Thank you very much.